Good morning and welcome to your Vasopressor Bootcamp, Part 4. What's up, you guys? It's your ER pharmacist, Lil Pharma. Today we're doing Part 4 in our Vasopressor Bootcamp series where we talk about all of our vasopressors, how they work, when to use them, when not to use them, any adverse effects. Let's get into it. Today we're talking about epinephrine. Epinephrine is very similar to norepinephrine with some important differences. So epinephrine has much more beta-1 activity, but it still has some alpha-1 and beta-2 activity as well. So it's mostly going to increase heart rate and contractility, but it also has that added benefit of squeezing the vessels just like norepinephrine does with that alpha-1 activity. So it's going to increase heart rate and blood pressure. So this is really great for your cardiogenic shock patients, especially early on in their therapy. Later on, we might want to choose something like a pure inotrope or an inodilator, but early on, especially if you are not sure what's going on, but you know they need more heart rate and contractility, and they also need a little blood pressure help, epinephrine can be a great first-line option, which, again, if you're following my SCCM mini-series, one of the new recommendations in the guidelines was to start epinephrine as your first-line vasopressor if there's cardiac dysfunction. So great for cardiogenic shock, especially initially. Can be used in refractory shock if you're adding on vasopressor. So typically we'll go norepinephrine, vasopressin, and then add epinephrine. Of course, you're individualizing this to your patient. It is not the same formula for everyone, but that's our starting point. Biggest adverse effects you're going to see with this one are tachycardia, of course, because it's hitting those beta-1 receptors. It does have an increased risk of arrhythmia compared to some of our other vasopressors like norepinephrine or vasopressin. And then you can see an increase in lactate, which is just problematic because it clouds the clinical picture. Epinephrine is not good for your patient who's already tachycardic, right? You don't need to hit those beta receptors any more than you already are. If you're trying to avoid arrhythmias, so maybe a patient has a history of arrhythmias, that could be an indication to avoid epinephrine. So epinephrine kind of does it all. You get your squeeze and your pump, but it has more risks than norepinephrine. So we're sticking with norepinephrine as our first line agent. Unless someone has cardiac dysfunction, then we're going with epinephrine. All right, that's what I got for you guys. Come back for more in this vasopressor bootcamp series. Bye.